In the last year, we revolutionized the treatment of advanced melanoma. And also now these treatments are available for the adjuvant. So we can say that we are able to get long-term benefit for about half of patients. And now we need to do a little bit more for the other half of patients where we are able not to reach this long-term benefit. So combinations probably is the right strategy. At the moment there are some interesting combinations among the immunotherapy field. So you know that anti-CTLA-4, anti-PD-1, it's an interesting combination but toxic. Now there are other combinations still interesting but less toxic that we should evaluate in randomized trial. One is the combination of anti-PD-1 with anti-LAG3 at the moment in phase 3, nivolumab and relatlimab. The HDAC inhibitors plus anti-PD-1, another interesting combination. And you know, last ASCO, we have seen the data about the Nectar, the pegylated L2 in combination with nivolumab seems to be also promising. And the local treatment, so the two-like receptors seem also to be interesting. Here at ESMO, we reported the trial in progress of IMO 2125 plus ipilimumab versus ipilimumab in patients refractory to PD-L1. Last but not least is the triplet target therapy with anti-PD-1. Here at ESMO, we have seen the data of KEYNOTE-022. There are interesting signals of activity, more for the patients with elevated LDH and with the performance status 1. So it's a toxic regimen, but maybe still important for the so-called bad patients with brain met, elevated LDH, high tumor burden. But looking at other data presented here at ESMO about the IMPEMBRA study from the Dutch group, the sequencing treatment of anti-PD-1 pembrolizumab, dabrafenib, trametinib, seems also to be effective with less toxicity. The treatment of melanoma changed during the last year. You know that before 2011, only 55% of patients were alive at 1 year. The majority of these patients died within the 2 years. Now, at 1 year, we have still alive 73% of patients, with 50% with long-term benefit. So the possibility to reach long-term benefit is something that now it's new for us. When you have a patient in front of us, we try to get this long-term benefit. But long-term benefit is just for half of the patients. We need to do more for the other one. So this is what we see. Of course, in some cases of very bad disease, fast kinetics, we need to look to response more than long-term benefit. And this can be done if there is the BRAF mutation with target therapy. But of course, we need to do more for these patients. Combination, again, is the most interesting strategy. And the combination of anti-CTLA-4 anti-PD-1, for instance, seems to be really important for patients with brain metastases. We'll see with the next trial the triple combination of BRAF MEK and anti-PD-1 if this strategy can be still important for this kind of patients with a very bad disease. That said, I think that in the future, with the new compound available, we will for sure increase the bar of the long-term benefit. Looking to the data that we have seen in the past year, there are some interesting data that probably will be important for the future. The combination of nivolumab with relatlimab, the anti-LAG3, seems to be really promising. It was tested at the moment in the patients previously treated with anti-PD-1. Now there is ongoing phase 3 trial that is exploring if in first line this combination that is less toxic than the combination of ipi/nivo can still give a little bit more of efficacy with respect to the anti-PD-1. Another interesting combination is the combination with HDAC inhibitor with anti-PD-1. We have seen the data of entinostat and pembrolizumab. Again, in the refractory relapsed patients to anti-PD-1, showed a very interesting data. Some local regional treatment to like receptors, so the IMO 2125 and the SD101 in combination, one with ipilimumab, the other one with pembrolizumab, really showed interesting results still in the refractory population. And lastly, the Nectar pegylated IL-2 together nivolumab in the phase 1 trial showed interesting response rate. At the moment there are randomized trial ongoing with this compound. and this for sure will add something to all that we have seen now in the field of melanoma. So looking into the melanoma data, the most interesting and probably new data presentation was the KEYNOTE-022. It's the first report in a randomized trial of the triplet BRAF MEK PD-1 versus BRAF MEK alone. Okay. So you know that the main endpoint was the progression-free survival, and this trial we've seen an interesting median progression-free survival. Unfortunately, this study was very ambitious because it was designed to reach an hazard ratio of 0.62 or less, and looking the progression-free survival, the median was really better for the triplet. So 16 months versus 10 months, 6 months more. And interesting, the curves start to be separated after 6 months. This means that pembro added something to the combination. That ratio was 0.66, 34% of risk reduction, but a little bit more than 0.62. So for this reason, it's not significant, but still interesting. Was toxic, yes, 53% of grade 3 and 4 adverse event, 40% of discontinuation rate. But if we look the performance in patients with elevated LDH, MPS1 was really interesting. And probably this may be something that in the future could be important in designing new clinical trial. Last information, overall survival curves seems to be similar, but it's important to know that in the dabrafenib trametinib arm, after progression, these patients were treated with immunotherapy more than, of course, the other three. So it's something like combinations versus sequencing in the game, so we can still with the sequencing get important overall survival. So looking to this data, probably the combination may be something in the future that could be useful for the so-called bad patients with brain metastasis, elevated LDH, high tumor burden. But there is also another interesting data in such way. So the IMPEMBRA study, it's a Dutch study with combination but also sequencing of pembrolizumab and dabrafenib trametinib at different points, different ways. So it's interesting to see that even with the sequence we can reach the same efficacy of the combination with less side effects. So this for the future will be important, not only for the bad patients but for all comers.